I'd like to thank you, Dr. Hale, for the invite in presenting this talk on rare interstitial lung disease. I've got very little time to present this, and hopefully I have enough time in 30 minutes. So I'm Nazia Chaudhuri. I'm a senior clinical lecturer at the University of Ulster in Northern Ireland. These are my disclosures. And I apologise that I've not got any interaction due to limited time, but also because I've had to record this presentation for you. So just to remind you that this is a classification of interstitial lung diseases, and you can define ILDs as those with known causes, such as those that are related to connective tissue disease or exposures, environmental exposures or occupational exposures, idiopathic interstitial pneumonias, and then the ones I'm going to cover are the rare cystic lung diseases, and then very briefly I will also cover organising pneumonia as well. So here's the first case. This is a 72-year-old female who presents with a 3-week history of breathlessness, fever and cough, with a past medical history of diabetes and hypertension, with saturations of 92%, respiratory rate 24, hemodynamically stable apart from slight tachycardia, and had bilateral coarse crepitations. The CRP was 150 with a raised white cell and neutrophilia, and this is her X-ray. So Dr. Sahel, if you would like to pause the video now for interactions, you can ask your audience what they think of this X-ray. Otherwise, I will continue my presentation. So she was diagnosed as having community-acquired pneumonia on the right side and started on broad-spectrum intravenous antibiotics and oxygen, had various virology, serology sent off, urine pneumococcal, Legionella, etc. Came back negative. Sputum was negative for AFB in cultures to date, and she clinically improved and was discharged after 5 days. She re-presented, however, to the emergency department 3 weeks later with ongoing breathlessness, didn't quite feel 100% when she was discharged, but now feeling breathless on washing and dressing. She'd poor appetite and lost quite a lot of weight since her admission, but denied any cough off and had a fever of 38 but no sputum. And a repeat white cell count was normal at 9.5 and the CRP was still elevated at 70. This is her X-ray. If you'd like Dr. Sahel to stop the recording now, and then you can have a discussion with your audience about what they think may be the potential reasons for her representation and the X-ray findings. So she has new consolidation on the left side this time, persistent consolidation on the right, but it looks slightly different to the previous X-ray. And so the differential diagnosis in this respect could be any of the ones listed here, whether she's had a further community-acquired pneumonia, whether the pneumonia has developed into complications such as a pulmonary abscess or even an empyema, whether this is now an atypical infection, whether it could be TB or even a vasculitis. She had some further investigations because she just wasn't quite feeling well, and proceeded to have a CT thorax and bronchoscopy. A bronchoscopy was normal with no growth and negative, and her blood test, autoimmune screen and ANCA was negative, UNEs were normal and urine dipstick were negative, and she had no other features really of vasculitis. So these are some images that I took to be representative, taken from Radiopedia. So I'm just going to show you some of these images and let you see these in your own time. So the suspicion was of an organising pneumonia. Again, she was started initially on broad-spectrum IV antibiotics because the initial suspicion with the temperature was always infection, but she really didn't feel any better after 3 to 4 days. And after 3 to 4 days, Her lavage has so far come back negative. Nothing had really come back as positive on any of the viral serologies. She was continuing to have low-grade temperature, continued to feel breathless, and the CT was reported as a potential suspicion of an organising pneumonia. She had peripheral consolidation, maybe with some traction bronchiectasis, and was commenced therefore on 1 milligram per kilogram prednisolone. And remarkably, there was a dramatic improvement. She felt brilliant. Breathing got much better within days. She was eating better. CRP decreased from 70 to 14, and she was home within 2 weeks follow-up. On follow-up appointment, her weight had also increased back up to 63. There was very little cough and sputum. Her breathing had improved, her energy was better, and she felt nearly back to baseline. She still had some few basal crepitations, and actually the biopsy that she had done, unfortunately, was only of the bronchial wall, and there was no lung parenchyma on the biopsy. So the plan was to repeat the X-ray when she got home. She'd also had a lung function that showed normal lung volumes but transfer factor of 50%, and she continued prednisolone for 30 milligrams per month and then review. On examination, after a month of review, she had some right basal crepitations, and the repeat X-ray is shown next. And this was her repeat X-ray. If you can recall, her initial X-ray, still not completely normal after a month, but much better compared to her initial X-ray that showed that peripheral consolidation. So this lady was diagnosed as having cryptogenic organising pneumonia. This is a diagnosis of exclusion. You really do need to exclude all other causes. Hence why it's called an organising pneumonia, because usually it presents like pneumonia, is treated as a pneumonia, but just doesn't resolve with antibiotics. It was first described by Davidson in 1983, and actually Epler described a similar entity, which was described in 1985 and described as bronchiolitis obliterans pneumonia. You get organisations within the alveolar ducts or alveolar of an organising pneumonia within the bronchioles, and they have typical pathological and clinical radiological features. Typically affects males and females equally. Within the later decades, 50 to 60-year-olds, more common in non-smokers, twice as common in non-smokers, and it tends to have a very subacute onset over many weeks, but it feels like pneumonia with a fever, usually a non-productive cough, malaise, anorexia, and weight loss. Some hemoptysis, chest pain, and night sweats are very uncommon, with mild breathlessness, and they develop over weeks with sparse crackles, and usually, as I mentioned, treated for infection for many weeks before the thought is that it could be an organising pneumonia. Like normal pneumonias, there's raised ESR, CRP, and neutrophilia. Lung function is normal in 75%, but can be restrictive with a reduced transfer factor. And the X-ray usually shows area of consolidation, which can be bilateral or upper lobe, can be patchy. In 10 to 50% of cases, it can be nodular opacities. And in 15%, the nodules are more than 1 centimetre. So lung cancer can also be in the differential. In the CT imaging, 90% of them show airspace consolidation and air bronchograms and what we call the reverse halo sign. 50% are usually subpleural. Lower zone predominant is more frequently. 50% will have small nodules along the bronchovascular bundles. 60% of cases will have ground glass, and 15% will have large nodules with this reverse halo sign. But often lung cancer or an abscess can be in the differential. And sometimes these are biopsied with a CT-guided biopsy to make sure that it isn't a lung malignancy. The differential diagnosis is vast. So as I've already mentioned, alveolar cell carcinoma, lung cancers, lymphoma, vasculitis can cause nodules, sarcoidosis, because you can get nodules along the bronchovascular bundle, atypical infections and TB, chronic eosinophilic pneumonia if it's subpleural, And also, you can't call it cryptogenic unless you exclude infection or drugs as a potential cause, because drugs such as amiodarone, carbamazepine, fluoxetine can cause these changes. And so often bronchoscopy is performed to exclude atypical infections, to exclude cancer, to exclude lymphoma. And when you do a biopsy, you'll see intraalveolar buds full of granulation tissue consisting of fibroblasts, myofibroblasts, and loose connective tissue. And really, a VATS is required to exclude other pathologies. But as you can see in this case, it was challenging to get a biopsy. A biopsy was attempted transbronchially, and it was inadequate. But actually, rather than go, she was too unwell to go for any definitive biopsy, such as VATS biopsy. And so treatment was made to actually give steroids and see whether there's a treatment response. And the fact that it was such a robust treatment response really made it likely that it was cryptogenic organizing pneumonia. So management of COP, there's no randomized controlled trials, but they really does respond really well to steroids. And it's probably one of the most steroid responsive diseases. And if it doesn't respond to steroids, that should alert you to the fact that there's something not quite right. And often it's because it's a lymphoma or a cancer. They clinically improve very quickly within 24, 48 hours. And usually you need to use high doses of 1 milligram per kilogram per day. And so usually we would start off with 60 milligrams for 4 weeks. And then after 4 weeks, taper. There's no evidence based. I usually reduce by 5 milligrams every week, but review the patient in every 10 or 20 milligram increments. So every 2 to 4 weeks, make sure the patient is getting better, because the relapse rate is really quite frequent. And so what I try to do is taper by 5 milligrams every week until I get to about 15 milligrams. And when I get to 15 milligrams, then I go down by 1 milligram a month. So very slowly, because relapse is very frequent. If a patient relapses, then you would be thinking about second-line agents such as mycophenolate. So that was a quick run through of cryptogenic organizing pneumonia. I've got the next 15 minutes to go through cystic lung disease. So I suppose the first thing to say is, what is a cyst? So the Fleischer criteria have defined a cyst as a thin-walled, less than 2 millimeters, spherical parenchymal lucency interface with normal lung. And this is an example here on the left. Very different to a cavity, which is gas-filled within consolidation or a mass, typically thick-walled, more than 2 millimeters, and can be more irregular than a cyst, which is then very different to a bulla, which is usually greater than 1 centimeter, again thin-walled, but usually accompanied by emphysema. And the causes of cysts are many, and I'm listing some here. You can define them according tumor suppressor syndromes, such as tuberous sclerosis or LAM, Birt-Hogg-Dubé neurofibromatosis. They can be neoplastic, so Langerhans cell histiocytosis, actually, although smoke-related, is defined as a neoplastic cause of cystic lung disease. Can be due to metastatic sarcoma. Infections such as pneumocystis can cause cysts. And then the very rare conditions, protein deposition diseases such as amyloid and light chain deposition, and then the inflammatory causes such as Sjögren's and antisynthetase syndrome. And small airway diseases such as hypersensitivity to pneumonitis and smoking can also cause cysts. It's important that you have a way of remembering these potential causes when you're thinking about a differential when you see a patient with cystic lung disease. So presentation can be very variable, but it can alert you to maybe what are the most common causes. So for example, if somebody presents with breathlessness and they have cystic lung disease, then you might be thinking more of the inflammatory causes such as Sjögren's and antisynthetase, or the very rare protein depositions, whereas Langerhans cell usually presents with breathlessness and a spontaneous pneumothorax. And Birt-Hogg-Dubé typically presents as a pneumothorax, as does LAM. But when lymphangiolymphomatosis, but that can also, as it progresses, present with breathlessness. So the mode of presentation can give you an idea of what the differential diagnosis would be. Younger age would make you think about Burt's Hogg and Langerhans and Sjögren's, and as you get older, you'd be thinking of the protein deposition diseases. But then also often they are found incidentally just because you're doing a CT for other reasons. And also not forgetting the extrapulmonary manifestations. So if you have any extrapulmonary manifestations, and we'll go through some of these, this could alert you to one or many of the diagnoses as well. So diagnostic approach based on the differential diagnosis, obviously history is very important, and typically they present with breathlessness and cough. If somebody's got a smoking history, you would be thinking of Langerhans cell histiocytosis. Family history of pneumothorax or cystic lung diseases, would you be thinking about the genetic causes such as Burt's Hogg-Dubé and tuberous sclerosis and Lamb? If there's history of recurrent pneumothorax, you'll be thinking about Burt's Hogg and Lamb. If there's coexisting skin diseases, so skin tags and rashes, then again, Lamb and Burt's Hogg-Dubé. But then also it's important to ask about connective tissue disease symptoms such as dry eyes, dry mouth. Raynaud's would make you think about lymphocytic interstitial pneumonia caused by Sjögren's. Examination is very important, particularly looking for skin lesions. So Burt's Hogg-Dubé, neurofibromatosis and tuberous sclerosis have distinct skin lesions that I will show you examples of. And then also mechanical hands would point you to the direction of connective tissue disease. And so if you have somebody with symptoms and cystic lung disease, then the diagnostic workup would obviously cover all that differential. So you would do an autoimmune screen and a myositis panel looking for Sjögren's and antisynthetase. You really should do a CT abdomen to look for renal lesions, because if you see renal lesions, and this would point to being Burt's Hogg-Dubé or Lamb associated with tuberous sclerosis. If you have VEGF-D available to you and it's elevated, then that would point to the tuberous sclerosis complex, but not all labs have this, and certainly in the UK we only have this available on research basis. And then depending on your suspicion, and we're going to go through the radiological features that will help you with that suspicion, you may then go on to do the genetics. So if you think it's Burt's Hogg-Dubé, you would do the folliculin gene. If you're thinking of Lamb, then you would do tuberous sclerosis complex. And if you're thinking of those very rare protein depositions, then you would need to do the free light chains and the Ben-Jones proteins. And biopsy really is reserved for a specialist review. The most important thing about a diagnosis is that you really should have a multidisciplinary team discussion, and that you don't necessarily have to biopsy these patients with cystic lung diseases, because other diagnostic tests will point you to the most likely diagnosis. And really, you shouldn't be going down the route of biopsy without discussing in a multidisciplinary team meeting. And so CT appearance is really helpful in diagnosing cystic lung diseases. The morphology, the distribution, and what the surrounding parenchyma look like will help gauge towards specific diagnoses. And so when you're looking at cysts, you should really be thinking about describing them as I mentioned, they're thin walls, so round cysts, whether they're lenticular, and I'm going to later on go through some of these classical features for the specific diagnoses, whether they have funny shapes, this is an example, whether they're septated, whether they're thin or thick-walled, and that would point you to specific diagnoses, which I'll go through later on. And then also distribution, whether the cysts are all evenly distributed throughout the parenchyma, whether there's basal sparing or whether they're predominantly central, and then whether the surrounding parenchyma is normal, as in this example, whether there are surrounding interstitial changes or surrounding nodules, as in the lower examples. And these would all alert you to specific diagnoses, which I'm going to go through later on. So you not only are you thinking about the history, but history of connective tissue disease, family history of pneumothorax, family history of cystic lung disease. But when you do your CT, how the cysts look, what their distribution is, and whether the surrounding parenchyma is normal or not, will alert you to specific differentials that should be at the top of your list. So here are the examples of potential differential diagnoses. And I'm just giving you some examples of different CT scans, and we'll go through those a little bit later. So here's an example of Birt-Hogg-Dubé, and I'll go through the characteristic features later. Small airways disease, such as hypersensitivity pneumonitis, can cause cysts. Antisynthetase syndrome is an example here. LAM, as an example here as well. Light chain deposition, neurofibromatosis, and 8-year-old non-smoker, and Langerhans cell histiocytosis. And I'll go through the characteristic cystic features that might alert you to each of these diagnoses. So here's a case. This is a 33-year-old woman who has a pneumothorax. It fails to resolve with conservative therapy, and that is with a chest drain. It keeps bubbling. We come to many, many days and it's still bubbling away. And the CT is performed, which shows lung cysts. So I'll let you have a look at these lung cysts. If you, Dr. Hale, if you'd like to pause the video to have a discussion with the audience about what they think about the morphology of these cysts, what they think about the distribution, and what the surrounding parenchyma looks like. So I will continue. These are thin wall cysts that are well defined. They appear to be evenly distributed in the image that I've shown you. And this is a female, so that always alerts you to one potential diagnosis that is more prominent in females. She actually went on to have a pleurectomy as a definitive management of cystic her pneumothorax, and obviously they performed a biopsy at the time, and she was diagnosed with lymphangiomatosis, and lung function was performed, which showed a FEV1 FVC ratio of 55% and a transfer factor which was reduced at 70%. And so this lady's clinical course is described here. She had pneumothorax initially and surgery. And you can see just an example of another patient's clinical course where when a patient got pregnant, their lung function got a lot worse. And this is a feature of LAM as well, that estrogen and pregnancy can make the condition a lot worse. And in this case, this patient was then prescribed an mTOR inhibitor, rapamycin. You can see the lung function stabilized. So this is just a clinical course from another case, just to describe an example. So LAM typically presents with recurrent pneumothorax. You get progressive airflow obstruction, so the ratio is reduced. It's exacerbated by estrogen and responds well to mTOR inhibition. And an abdominal CT is really important in LAM, because you also get these typical renal angiolyomas as well. And you can see a very large one on this side here, and smaller ones on the opposite kidney as well. And so management of these patients is managing their lung disease with beta agonists and monitoring their lung function. You do need to give these patients LAM specific advice with regards to pregnancy particularly. And the renal disease often is managed by embolization of the angiomyolipoma and treatment of hypertension. And really these patients should be referred to the regional genetics service, particularly because this patient had a daughter and was found to have a tuberous sclerosis complex. So LAM is very rare, affects 9 per million women, can be sporadic in 60% of cases. And the key thing with tuberous sclerosis, and the reason I mentioned the examination, is that you can get facial angiofibromas, which will alert you to LAM. You need to do a renal CT to look for these bilateral angiomyolipomas as well. And obviously this patient also asked whether this was inherited. And this is just descriptions of the skin lesions. As I mentioned, it's 85% have de novo sporadic mutations, and the skin changes can be very subtle. And these are just some of the features that you might see with the skin angiolyomas on the skin, with skin pigmentation as well. And the pulmonary manifestations of LAM is that you get very evenly distributed thin wall cyst throughout the parenchyma, very different to Langer's cell histiocytosis, but this example is a severe form of LAM. And they often present with recurrent pneumothoraces as well. And the other thing that they present with as a complication is chylous pleural effusion as well, because they get lymphatic involvement. They present with pleural effusions, and if you pop a needle in that, you get a very milky exudate, which is a chylous pleural effusion as well. And as I've already mentioned, you get the extrapulmonary manifestations, which are the angiomyolipomas as well. So the ERS diagnostic criteria for LAM, for definite LAM, you need to have a characteristic or compatible lung CT and a lung biopsy fitting the pathological criteria, or you can have any of the other features. So often you don't need to do a lung biopsy, because often you'll see an angiomyolipoma on the kidney, or they might have presented with a chylous effusion, or they have a lymph node involved with LAM, or they have a TSC mutation. So often I don't send these patients for biopsies. I often look for the other extra lung features and maybe send them for a TSC complex mutation. And the VEGF D greater than 100 is also within this criteria now, but this is not universally available to everybody. So you do not necessarily need to do a lung biopsy. And as I've already mentioned, it's very rare. It's estimated to affect only 150,000 people worldwide. It's caused by infiltration of the lungs by neoplastic smooth muscle cells, and it's associated with tuberous sclerosis. So 70% of patients have pneumothorax, and 73% are recurrent. They can get lymphatic obstruction, which leads to the chylothorax. It's also associated with these abdominal angiomyolipomas, and the CT shows variably sized cysts distributed throughout all the lung fields with normal parenchyma, and the lung function is typically obstructive, or it gives you a mixed picture. And if you've got a tuberous sclerosis mutation, then the patient may also have cysts in the brain, which means that they present with epilepsy as well. And management really is management of the pneumothoraces, and usually definitive management if you've had the first one, bronchodilators, and if there is progression of lung function, then you will consider mTOR inhibition. But really, LAM should be managed. In the UK, we have one LAM centre throughout the UK that manages all these patients. And so, I would say that you would have very few cases in Pakistan. But if you do have them, somebody should be cohorting them and looking after them themselves. And you only really use the mTOR inhibitors if there is progression in lung function. And usually a lot of patients with LAM are just monitored. And this is just an example of how you can make a diagnosis non-invasively using the VEGF-D. This is a study that measured VEGF-D in patients with LAM and control, and you can see that there is a very clear separation, and that's why the 800 cutoff has been used. And so if you've got cystic lung disease, it's probably LAM. You should do an abdominal CT looking for angiomyolipomas or chylous pneumothoraces, or do a mutation. And if definite LAM is present, then you don't need to do a VEGF-D. But if it's a probable LAM, because all these are absent, then maybe a VEGF-D would be very helpful. Because if it's above 800, then that would give you a definitive LAM diagnosis. If it's below, then that's when you may need to do a biopsy if you've got none of those other extrapyramidal features, parenchymal features. So it provides you with a non-invasive diagnosis of LAM in about 70%, adds 10% to the diagnostic algorithm, and it's been included in the ATS JRS guidelines now. And the most important thing is really looking at disease progression over time in these patients. And you can see that the disease progression is very variable from patient to patient, as you can see from these studies. Some patients remain stable, as you can see in the green. Some decline very rapidly and have poor baseline lung function, and some decline gradually. And you wouldn't institute mTOR inhibition in somebody with stable disease, and you would really only institute mTOR inhibition in those with progressive decline. The decline can also be linked to, obviously, their dyspnea grade. And survival of LAM is very wide, from 4 to 40 years, 91% survival at 10 years, and the median survival is 29 years from symptom onset. So the prognostic factors in LAM can be divided as those that are good and adverse, and then they can help you decide on treatment with mTOR inhibitors. So obviously, if you have progressive dyspnea and weight loss, then that would be an adverse event. Older patients usually have better prognosis. If you're postmenopausal, you're more likely to have good prognosis. If you have a lower VEGF-D, if your lung function is stable or preserved, and you're not hypoxic and you have an absent bronchodilator response, they are good prognostic features. And treatment of aggressive disease is with mTOR inhibition, and we can see that mTOR is activated in LAM biopsies, as you can see in these biopsy samples, and that if you give rapamycin or sirolimus, then you can reduce the mTOR activation quite significantly. And so it's made, it is part of the ATS JRS guidelines now, but I would strongly advise that it really should be done within a specialist service as well. And this is just showing in the UK experience that rapamycin therapy has improved lung function in the patients that they've used it in as well. Rapamycin also has been used quite successfully for chylous complications. It's effective for lymphatic disease. It reduces the need for chyle drainage and can have a full effect for over 1 year as well, as you can see in these schematics. After treatment with rapamycin, the effusions are completely resolved. And similarly has been shown to have a response with angiomyolipomas with regards to size. So a lot of renal angiomyolipomas are often treated with mTOR inhibition as well. So a lot of patients would be on sirolimus as well. So general measures, obviously you need to give advice about pneumothorax, advice about seeking help if they get severe pain or breathlessness that's sudden, if they get abdominal pain, to seek help because this could be a bleeding angiomyolipoma, ensure they get vaccinations, and certainly advice about pregnancy. And really it is high risk to get pregnant, and they really need to plan it closely with their physicians. You can use bronchodilators for the airflow obstruction, pulmonary rehab and patient support, and really most importantly, avoid smoking, don't use estrogen containing contraceptive pills, no HRT as well. And these are just evidence showing improvement in lung function with bronchodilators and the impact of pulmonary rehab. So very quickly, I've got very little time. This is a 24-year-old woman admitted with pneumothorax, no medical history, smoker of 10-pack year history, and this is her x-ray. Dr. Sale, if you've got time, you can pause the video and allow people to comment on this X-ray. And this is the CT that was performed. And if you'd like to pause the video and allow people to comment on this CT with regards to the type of cyst, the distribution, the morphology, and the surrounding lung parenchyma. I think the important thing here is that these cysts are in the upper zones. There is basal sparing. They are very thick-walled and they are bizarrely shaped. You can see these bizarre shaped, and they are very variable, mainly upper lobe. And this is a big clue as to the diagnosis with the basal sparing. So Langerhans cell histiocytosis gives you upper lobe predominant bizarre shaped cysts, often with very thick walls, and it occurs in 1 in 100,000 people and more common in smokers, but young smokers, very young at the age of 20 to 40, and they don't have to smoke very much. 60% will have cough and breathlessness, 10% with a pneumothorax, 25% with an abnormal X-ray. It's more common in males than females. And the CT will show upper and mid-zone predominantly bizarre shaped cysts. Lung function will be mixed, obstructive and restrictive. And if this is multi-system Langerhans cell histiocytosis, which is very rare, 5 to 15%, then they will also have extra pulmonary features, such as diabetes insipidus, bone disease, skin features, and fatigue and weight loss. So often when I have a patient with cystic lung disease, I do ask about excessive thirst and any bone pain as well, particularly if they have an LCH pattern. I'll be very honest with you, I've got a handful of Langerhans cell histiocytosis patients, and I've only had in my 10-year experience one patient with multisystem LCH, and they actually presented in childhood, and they came from the paediatricians. Outcome is good, 50% survival, 90% at 10 years, but there is a 17 times increase in lung cancer, so it's really important treatment. Smoking cessation, steroids are often used with very, very little evidence base, and cladribine is used in specialist centres, but again, this really should be used in trial settings. Cladribine targets the MAP kinase inhibition as well, and it's felt that BRAF mutations, it's linked to BRAF mutations. So, and it's called a neoplastic condition because of the clonal Langerhans positive dendritic cells proliferation. As I mentioned, 80% of pulmonary Langerhans cell histiocytosis have BRAF mutations, and they have downstream activation of MEK and ERK as well. And so BRAF inhibitors are available for cancer and are being tested in randomized controlled trials for Langerhans cell histiocytosis as well. And cladribine for Langerhans cell histiocytosis, again, should really only be used in research purposes. This is a study in thorax that showed the impact of prednisolone for LCH does nothing, but then cladribine showed an improvement in all these parameters in lung function, in FEV1, FVC2, lung capacity, transfer factor, and saturations, and improvement in the CT scan. But these are all small studies, and really we need a randomized controlled trial of cladribine, and really should only give cladribine in specialist centres. So finally, onto Birt-Hogg-Dubé. Very rare, 2 cases per million. It's a germline loss of function mutation in the folliculin gene, 84% autosomal dominant, and it's chromosome 17. And the lung cyst is almost uniformly present in 70 to 80%. 30% will present with multiple pneumothoraces at young age, less than 40. And they also get renal and skin manifestations, but they're less common. And there's a strong family history usually of pneumothoraces. Folliculin acts as a tumour suppressor, so you'd look for mutations in the folliculin gene. And the diagnostic criteria for Bertov-Dubé, you either have one major or two minor required for diagnosis. The major are more than 5 fibrofolliculomas, and this is an example, and one at least histological confirmed, or the germline mutation. And then you need to, if you haven't got any of these, you need to have 2 of the minor criteria, which are usually multiple lung cysts that are usually basal and central, and they're usually less than 1 centimetre, and you can get these elliptoid cigar-shaped cysts. So if I ever seen an elliptoid cigar-shaped cyst, I think Bertov-Dubé, particularly if it's basal dominant. And the other minor criteria is an early onset renal cancer or a first-degree relative as well. Management of Bertov-Dubé seldom develop progressive respiratory failure. Lung function can be abnormal, but very mildly. And really, the management is about planning for pneumothorax. Should advise patients about the risk of flying and that they really never should dive as well. And you should really do early surgical treatment for pneumothorax, offer pleurodesis after the first pneumothorax because recurrence is so common, and then genetic counselling as well. And they should also have annual MRI screening for renal cancers. And finally, this is a patient with mechanic hands, and they have these lung cysts, but they have background non-specific interstitial pneumonia features in the parenchyma that should alert you to the fact that this is a connective tissue disease. Background lung changes is very unusual in lamb, and you should be thinking of Sjögren's and antisynthetase syndrome. And the cysts are usually uniformly distributed, similar to lamb, but the key thing is that the background lung disease will be normal in lamb, but in connective tissue diseases you might see nodules or a non-specific interstitial pneumonia pattern. And so Sjögren's causes lymphocytic interstitial pneumonia. This is an example of a 53-year-old man with fever and pleuritis, was Roux and La positive, had cysts with some background ground glass and some pleural disease. And the key thing about these cysts, they tend to have blood vessels in the outer rim of the cyst, and that should alert you to the fact that this might be lymphocytic interstitial pneumonia. You can see these blood vessels in the outer rim. So whenever I look at cysts, I look for these because that will alert me to the fact that this might be LIP. You could do a bronchoscopy and lavage, and they would have a lymphocytosis of greater than 30%. They can often start as central lobular nodules, but be wary that LIP is associated with lymphoma. So if you have enlarging nodules, you need to make sure it's not lymphoma as well. The final cause, lymphoproliferative diseases, can also cause cysts. This is somebody with a progressive large granular lymphocytic leukemia that had cysts, normal CT abdomen, normal antibodies, and really the only way you can diagnose this is by doing a biopsy. Patient had severely impaired gas transfer. And then finally, amyloidosis, which can be primary or due to Sjögren's or due to malt lymphoma. Again, this is diagnosis or exclusion. You think about other diseases, and really amyloid is only diagnosis by seeing the bifurcation green, apple green colour on biopsy. And then finally, the very rare light chain deposition where you get monoclonal immunoglobulin deposition secondary to lymphoproliferative disease. And you might see this if you have Benz-Jones proteins or raised gamma monoclonal immunoglobulins in the blood. And so these are the rarer causes of cystic lung diseases. And I'm sorry I'm rushing, I know I've run out of time. Neurofibromatosis is another autosomal dominant neurocutaneous disorder. Often there's coexistent emphysema because they're smokers. Case series has shown that lung cysts are usually in the upper lobes, but you can get basal reticulation, and they usually have significant lung function loss. And so smoking cessation is really important, but they also have the typical cutaneous features as well. But these are examples of small airway disease. So smoking can cause cysts, asthma can, hypersensitivity pneumonitis, and bronchiolitis as well. And often with hypersensitivity pneumonitis, you get these tiny nodules associated with the cysts as well. And so this is just a summary, just to give you, so that you can think of the rare causes and how you can try and think of it as the common presentations, the distribution, the shape of the cyst, the sizes, what's happening to the parenchyma, and what you expect in lung function, and whether there's any extrapyramidal causes. So LAM is usually a female menstrual variation presented with pneumothorax and breathlessness. They have cysts, lots of them, throughout the lungs. They're variably sized but round, uniform size. They can have effusions, usually obstructive or reduced lung function, but they could have angiomyolipomas and lymphatic disease for TSC features. LCH is usually male and female equivalent, but they have bizarre shaped cysts in the mid and upper lobes associated with smoking, variably sized. They may have respiratory bronchitis, lung function usually obstructive, and rarely they'd have a rash. Bertog-Dubé, usually you have a family history. The cysts are in the lower lobes and centrally. You get these elliptoid cigar-shaped cysts. Usually lung function's normal, but look at the skin and look for renal cancers. And LIP, think about connective tissue disease symptoms, dry eyes, dry mouth, Raynaud's. They are throughout the lungs, nice and round. They may be septated, which would make you think LIP. If you've got adjacent blood vessels, would make you think LIP. Uniform size, you might get some nodules and ground glass with lung function abnormality, and that would make you think connective tissue disease. So I think I'm going to have to stop there. I was asked to cover acute interstitial pneumonia. I think the only thing I will say about AIP is that, again, it's a diagnosis of exclusion. It's usually a rapid onset of breathlessness and cough with no other relevant history, looks like a pneumonia and often gets treated as a pneumonia, but you have a rapid decline and the patient usually gets intubated and ventilated, and they have this diffuse ground glass that almost looks like an ARDS picture. And you send off all your cultures and nothing comes back positive. Patient doesn't get better with antibiotics, and eventually you think about calling it an acute interstitial pneumonia, and you would think about maybe giving steroids, but I wouldn't do that for at least a week, 5 to 10 days of after antibiotics. So usually they get treated with broad spectrum antibiotics, antifungal cover. It's a wide differential: infection, vasculitis, heart failure, connective tissue disease. So you do need to do all your extended panel, your autoimmune screen, look for MDA5, cultures, HIV screen, TB, bronchoscopy and lavage, and it's a diagnosis of exclusion. So summary, I have done a whistle-stop tour of the rare interstitial lung disease. Organising pneumonia and AIP are a diagnosis of exclusion. Exclude drugs and connective tissue disease. Think about MDA5, which is an antisynthetase syndrome for acute interstitial pneumonia. And for lung cysts, there's a wide differential, but look for those features, autoimmune features, the distribution of the cysts, the family history, because that can give you clues as to what the diagnosis is. So sorry for rushing through that, but I hope that was helpful for you, and I apologise that I've really gone over time.